Okay, thank you. Thank you, the host. And I'm so honored to have this opportunity to share with all the overseas orthodontists with our knowledge and the clinical experience about the new appliance we use for the last decade to treat this kind of severe Skeletal class 2 patient. So it's okay now? So my name is Xu Ziqing, it's Chinese name, and my topic is about clear orthopedic appliance S8-SGTB in correcting severe class 2 jaw discrepancy. And I work in Shanghai, China, and Shanghai Taikang Bible Dental Hospital. Actually, I'm on behalf of this huge group, and you can see in the middle one, this gentleman, and he is also my boss. And this one, and he's the leader and also the pioneer of the whole philosophy and treatment mechanism and all the appliance. And he's the real hero. And Professor Gang Shen got his master degree in 1991 in Shanghai and the medical university, and got his PhD in Hong Kong U in 2000. And then he worked as the head of Department of Orthodontics in Shanghai Nance Hospital, which is also the top 3 dental hospital in the whole China. And then he worked as a professor in University of Sydney for 4 years. And after that period of time, he come back to China and work as the chairman of the Department of Orthodontics in Shanghai Jiangsu University, and also the vice dean of the dental school. And at that time, I followed the Professor Gang Shen and started my orthodontic career. And in 2016, we moved from Shanghai Nance Hospital, the government hospital, to a private one, to Shanghai Taikang Bible Dental Hospital, which is also the largest DSO dental group in the whole China. So if you guys have any opportunity to visit Shanghai, please come to our hospital. It's in the real center of Shanghai. So this is my career following Professor Gang Shen to study my orthodontic experience. And I finished my master's degree in 2011 and get my PhD in 2016. And I also work as an original member in developing this new clear version of SGTB. We call it S8. So this is the content of my lecture today, and we have the 3 topics. What is Smarty S8-SGTB, and what is the indication of this appliance, and how S8-SGTB works? And actually, we have the whole day lecture if we have if you have enough time in the future. So it will cover all these aspects of this appliance, but we only have 1 hour this evening, so I'm trying to finish all the 3 topics to you guys. So what is S8-SGTB? This is the origin of the S8-SGTB, the fixed twin block appliance. We call it SGTB, Sagittal Guidance Twin Block. So we have used this kind of appliance for many years, for like 100,000 patients already treated successfully in China. And we also published many articles. We use this kind of appliance to fix very severe class 2, Skeletal class 2 patient. This is quite the typical patient. I will go very brief review of the patient. It's a 12 years old young boy, and you can see class 2 molar relationship climbed upper and lower incisors, and deep overjet and deep overbite has some space in the upper jaw. So this is typically a retruded mandible. So we can use this bonded SGTB to move the mandible forward. And after the stable position of the mandible, we remove the appliance. We bond the braces, align the teeth, close the space, and close the gap between upper and lower in the buccal segment, and finish the case. So it's class 1 molar, class 1 facial profile. So everything get perfect. So it's quite typical case we treat with this kind of fixed or traditional SGTB to treat this kind of class 2 patient. But this kind of traditional fixed SGTB has many disadvantages, like its lack of aesthetics. In our clinic, we have many adult patients, especially young ladies. They worry about this kind of bulky red plastic we put in the mouth. They don't want this. They want a very aesthetic treatment. And also the oral hygiene. You can imagine when the patient wears this kind of appliance, it's a huge, bulky appliance. It's quite impossible for them to clean the teeth perfectly, especially for the teenagers. And also lack of efficiency. That means if you want to align the upper jaw, the upper dentition, that's possible because we can have some expansion for this upper piece, and we can align the frontal teeth of the upper of the maxilla dentition. But it's impossible to expand align the lower dentition when we use the kind of appliance because the lower piece is removable. We have some add-on clamps and the ball clamps. It's a removable one, so it's lack of efficiency. And also, when we remove this kind of appliance, especially in the upper one, we will get very huge gap between upper and lower buccal segment. It's open by the buccal segment. So it's very inconvenient, it's very uncomfortable for the patient when we remove this appliance. And also it's very inconvenient to do that. So we want to make a new version of SGTB. So we will take a full advantage of the clear aligner. So we make this. Actually, we start to use this kind of a new appliance since 2013. So it's like 10 years ago. So why we call it S8 is like a number. 8 in China is lucky number. So SGTB means sagittal guidance twin block. So it's a new version of SGTB. And we got anatomic occlusal splines and also locking appliance in lower and both upper and lower. So interactive surface will maintain the forward position of the mandible. So we like lock the mandible in the forward position. So this is the S8-SGTB in vitro and vivo. So the next topic is what is the indication of S8-SGTB. So before we start this, talk about the indication, we want to introduce the new diagnostics classification proposed by Professor Gang Shen. So he's really a brilliant guy who invents or who proposed a new classification. Everyone knows in the past we use angle classification, but the pitfall of the angle classification is we only describe the molar relationship in angle classification. We don't have any other occlusion, other information like the etiology of the malocclusion or the dental facial deformity and the treatment plan and any other skeletal problem. So we can just describe the molar relationship, use the old traditional angle classification. But Professor Gang Shen want to provide or propose a new classification which can divide and which can reveal the etiology of the malocclusion, the etiology of the dental facial deformity, and even we want to help every orthodontist to make the right or proper decision treatment plan for the treatment. So just like these two pictures, we can see the protrusion of the maxilla and the retruded mandible, the lack of the trim prominence. But can you imagine beneath the soft tissue, what can we get? We can have, it's quite similar soft tissue facial profile, but beneath the soft tissue, we can see it's a huge open by horizontal hole open by the left one and the deep curve speed in the right one. So the etiology and the treatment plan of these two kind of patients is totally different. So how can we use just one classification, class 2, angle class 2 classification for this kind of treatment? So it cannot provide any information. So Professor Gang Shen, he tried to have the new classification and diagnostic classification. So we divide it to three types: the facial prognathism, the facial reconnaissance, and the facial asymmetry. It's three types of the new classification. So today we want to focus on the facial prognathism. So facial prognathism, we have five different types. So I will go very briefly of these five types. The first one is dental alveolar originated. So why we call it dental alveolar originated? That means for this kind of patient, the morphology and the position of the upper and lower jaw is normal. The jaw is normal, so relationship is normal, and the morphology is normal, the size is normal. But because of the crowding, maybe lack of the tension of the muscle of the lip muscle, the upper and lower teeth proclined, just like this animation. The teeth proclined, so that will produce the protrusion of the upper and lower lips. Maybe crowding, maybe some kind of the lack of lip tension. And also the molar relationship is still class 1. So for this kind of patient, the treatment protocol is simple. We can extract the teeth, or non-extraction. We can close the space with mini screw, maybe use a liner, maybe use the traditional appliance or lingual appliance. So the key is we want to balance the myofunctional. So we want to just retract the teeth. We put the upper and lower frontal teeth in the right position. The facial profile will get better. So it's just like a pure dental problem for the patient. So the next type is skeletally originated. So it's totally different, totally opposite kind of patient. That means for this kind of patient, the maxilla is overgrowth. So we can see the bulky alveolar bone. So because the maxilla is overgrowth, so it have enough space to accommodate all the teeth. So the frontal teeth is not proclined. It's very straight in the frontal area. It's very straight. And also the overgrowth of the maxilla will be like 3-dimension. It's not just like sagittally. It's about the vertical overgrowth of the maxilla. So we can see gummy smile when the patient smile. And also in the transverse dimension, if the overgrowth of the dental arch, the back teeth will like camouflaged, inclined palatally. So we can see the posterior teeth will palatally inclined. Still, we get class 1 molar. So it's kind of like this. It's overgrowth maxilla. So because of the overgrowth of maxilla and mandible, so we will get the protruding mandible. Also, we can have the vertical pattern of skeletal originate. That means if in the past we call the high angle patient, like the clockwise rotate mandible, it will cause increased lower facial third and the lack of the trim prominence. So this is another kind of skeletal originated pattern. So this is typically two different kinds of protrusion patients. The first one is dental alveolar originated, and the right one is skeletal originated. You can see it's quite different. The left one is just proclined teeth. You can see the alveolum is very thick, but you can see in the right hand side, it's like bulky alveolar bone. So it's like it's a skeletal originated. So it's totally different. We can also see the gummy smile. You can see, if you see the combined CT, you can see the straight straight frontal teeth, and you can see thickness, the increased thickness of the alveolar bone. So it's very typical. So for this kind of patient, skeletally originated patient, the treatment protocol will be maybe surgery if the patient have very demanding, very high demanding of the aesthetic goal, we can use surgery. But if the patient refuse surgery, maybe we can have some extraction or non-extraction. But if we decide to extract the teeth for this kind of patient, the top control of the frontal and the vertical control, especially for the skeletal, for the vertical pattern, is so important. So in my clinic, I will use customized lingual system, which is like because we use a ribbon wire, arch wire, so it's brilliant in vertical control, and also the customized lingual system can provide perfect torque control in the frontal. But for this kind of patient, if we want to treat the kind of this patient with aligner extraction, it's a mess. It will cause the mess of both the occlusion and the facial profile. So this is the next type is we call the mandibular positioning originated. That means for the maxillar, the size and the morphology of the maxilla is normal, maybe proclined because of the lack of the train, lack of the tension of the lip, maybe crowding, but the lower jaw, the mandible is retreated. So that means that they have some jaw problem because of the lower jaw is retreated. So when the lower jaw is retreated, so what we will get in the dentition, then we will see deep overjet, deep overbite, and deep curve speed because it's a long-term camouflage by the patient. And also we can see class 2 molar relationship. So it's like typical intraoral photos of this kind of patient. And retreated mandible, but upper frontal teeth may be proclined, but maybe sometimes we get space. So for this kind of patient, the treatment protocol, we can use S8-SGTB. So the fourth type will be combined skeletally and mandibular positioning originated subtype 1. So we have combined. So why we say it's combined? So it's combined the skeletally originated maxillar and the mandible of mandibular positioning originated. So it's combined this kind of two type together. So, and we call it the subtype 1. So when we say it's combined subtype 1, that means the upper frontal teeth is straight. It's straight, but with the retreated mandible. So because the mandible is retreated, so still we can see 3 dips. That means 3 deep overjet, deep overbite, and deep curve speed. And also we can see the class 2 molar like this. So we can see very protruding maxillar and retreated mandible, and it's a cephalometric. So also this kind of patient, we recommend we can use S8-SGTB to treat this kind of patient. So for the last type we call is combined subtype 2. So it's quite like class 2 division 2 in the past angle classification. We see the page like this. We have the very much climbed upper incisor. So for this kind of patient, sometimes the patient's lateral profile is camouflage. Why is camouflage? Because for this kind of patient, the lip tension is very strong. So it will force upper incisors move lingually, so it's retrocline. So the lip is not thick, it's very thin. And for this kind of patient, the trim prominence is also very good. So with very thin upper lip and the prominent chin, so the patient's lateral profile is acceptable. Even some kind of this kind of patient is beautiful profile. But still, if we want to know the etiology of this patient, that's because the mandibular retrusion. So we can still see three dips. That means deep over jet, deep over bite, deep curve speed. So this is so for this kind of patient, we also recommend we can use S8-SGTB to treat this kind of patient. So after we finish this 5 type, so we want to answer the question. So what's the indication of S8-SGTB? That means if you see any patient with mandibular position problem with mandible retrusion, that means mandible retrusion, we can use S8-SGTB to treat this kind of patient. For example, for all this case, and with the mandibular retrusion patient, we can see deep overjet, deep overjet, overbite, and deep curve speed. So in Chinese, we are say sanction, that means 3 dips. So if you guys see 3 dips in the mouth, you can imagine, you can just make a conclusion very briefly. That means the patient maybe have some problem with the jaw position. We can use S8-SGTB to correct this kind of patient. So I will show you some simple some case very briefly like this. It's like more than 55 years old female, deep overjet, deep overbite, class 2 molar, deep curve speed, crowding. And for this young lady also, you can see full unit class 2 molar, deep overjet, deep overbite, deep curve speed, and very protruded maxilla. And for this one, reclined upper incisor, we call it subtype 2. And for this gentleman, you can see full unit class 2, very protruded mandible, and gas space in the upper and the narrow dentition. So, and also for this one. So, and for this one, we already extracted 4 teeth, class 2 division 2 patient. So for all this kind of patient, what can we do if we don't use our new appliance? Maybe we can distalization from full unit class 2 to class 1. It's quite impossible if we want to distalize the like 6 millimeter for upper arch. It's quite impossible. So you want to extract the teeth, it's still very deep curve speed. Overjet and overbite, if you want the extraction, so maybe sometimes we will have some problem with the space closure. So you want surgery, but quite a few patients will accept the surgery, especially in China. Maybe for this class 2 division 2 patient, you want to proclination, the upper and lower incisor, but after you procline, the position of the lower jaw won't change. And then we'll have a huge gap, a huge overjet and overbite, and then we can't solve the problem. But now we can use S8-SGTB to treat this kind of patient. We can use this appliance to move the mandible forward, and at the same time we can align the teeth. This is the 50 years old female. You can see the treatment outcome. It's perfect. We can achieve class 1 molar. We can fix the overjet and overbite. We can make the facial profile better. You can see much younger. And for this patient, recline upper and lower incisor, we can improve the facial profile. And also for this gentleman, you can you imagine? It's like a surgery case. You move the mandible forward, make the occlusion better, make the facial profile better. All of these patients are adult patients. You can see also this one. So this is the indication of S8-SGTB. If you don't want to use this, the new diagnostic classification, if you just see deep overjet, deep overbite, deep curve speed, if you see class 2 molar relationship, if you see the patient maybe have some retrusive mandible, you can use S8-SGTB to treat this kind of patient without surgery, even without extraction. So what's more? So sometimes in China, we have many patients who will suffer from the condyle resorption due to the interference, maybe due to the very stressful. So like this kind of patient, 23 young lady, complain about the retreatment lower jaw and can't bite in the frontal. You can see the horizontal open bite. So this patient, why this kind of patient, we have the huge gap in the frontal, but we don't see 3 dips. We don't see deep overbite and deep curve speed. Because this kind of patient, he's like a pathological mandibular retrusion. That means the patient in the original position, the patient can bite in the class 1 position. So the frontal teeth can touch. But because the condyle has been resorpted, you can see very small condyle. You can see the condyle morphology is abnormal. Because the resorption of the condyle, so the lower jaw can move clockwise and downward and backward. But sometimes the patient want to bite, so still the mandible can still move forward to get the bite. So that we call it COCR discrepancy. So for this kind of patient, we won't see 3 dips. We want to see deep overjet, deep overbite, and deep curve speed. We can only see what? We can only see deep overjet, but a very shallow curve speed and shallow overbite, like this patient. So it's very typical condyle resorption patient. So still, we can use S8-SGTB to treat this kind of patient. You can see it's very stable. And the patient facial profile and occlusion has been improved a lot. And I will show you another case who suffer from the unilateral condyle resorption. And this poor young lady who just finished his orthodontic treatment, finished his orthodontic surgery. And this is what we get after surgery. You can see lower jaw shift to the left-hand side, class 1 molar on the right-hand side, class 2 molar on the left-hand side, and the increased overjet in the buccal segment here, and decreased overjet here. You can see the shifted midline. So what can we get after surgery? You can see the condyle on the left-hand side. It has been resorpted, and maybe it's resorpting now. So the patient is suffer from the unilateral pathological mandibular retrusion. So that's why the mandible moved left-hand side gradually. So what we do, we remove the braces, we put appliance, and we fix the asymmetry. We move the mandible forward. At the same time, we correct the shifting midline. And we want to increase the space between the condyle and the fossa, so that will help us to stop the resorption of the condyle resorpting. You can see this is after phase 2. This is the whole treatment plan. The whole treatment. After the whole treatment, we achieve class 1 molar, and we correct the midline, and we give the patient the perfect occlusion. And you can see the smile, the facial profile. If you see the condyle morphology, you can see this one is before everything starts. It's before every treatment. And this is what we get when we receive the patient after surgery. You can see the condyle resorpting. And this is after the phase 1, after we move the mandible forward, use S8-SGTB. And this is after the whole treatment. You can see the change of the morphology of the condyle. And also we can make the 3D computed CT image. We make a 3D superimposition for this patient to check the condyle remodeling. You can see the inner morphology is before treatment, after surgery. The outer one you can see is after all the whole treatment. We get a new bone formation for the condyle. So what's more, we can use S8-SGTB to treat. we can say many retreated, many extracted case. So all these extracted or retreated case are treated by S8-SGTB. I just show you one case. It's definitely a surgery case. It's very severe. It's only 26 years old young gentleman. And he complained about the deep bite and chewing problem, snoring, and the patient has 4 teeth extracted already. You can see the facial profile, definitely a surgery case. And the patient just see many dentists and many orthodontists and many orthodontic surgeons. Everyone want him to have a surgery, but the patient don't want to have surgery. So this is the intraoral photo. You can see the occlusion, the full unit class 2 for both sides, and the very severe deep bite in the frontal. You can see the curve speed. You can see the condyle has been resolved, and you can see the periodontal condition. It's terrible. You can see the lower incisor has been impinged in the palatal tissue, and also the condyle. And you can see the periodontal condition. The alveolar bone is very thick. It's very thick. It's very thin. You can see. So the teeth just like in the, it has no support for both upper and lower incisors. So we made the mandibular advancement simulation for the patient. It's much better, right? So that means if you can successfully move the mandible forward, so it will help the patient have better airway and better facial profile. So this is a simulation, but you can see the huge gap. That why? Because the patient has very steep curve speed, so we will have a huge gap in the buccal segment. So this is the animation. We use phase 1 treatment. You can see we try to align the lower curve speed, but quite impossible to align the lower dentition because the periodontal condition. And this is the patient where this S8-SGTB appliance. It's a phase 1 treatment. So at that time, we want to close the open bite in the buccal segment. But if we just finish the patient with aligner, clear aligner, it will cost many time. So we talk about the patient, we may change to the fixed appliance to have some box elastics to make the open bite fix quickly. So the patient will bond the braces and put some box elastic in both sides to achieve the interdigitation. And we close the space, it's a finish. So can you imagine we use S8-SGTB together with the braces, we can fix this patient. You can see the morphology of the condyle has been changed. You can see the lateral profile. You can see the curve speed has been flattened. And also the facial profile has been improved a lot. Still, it has some small change, but it's been nicer, right? So this is all the indication of S8-SGTB. If you see reducing mandible with 3 dips, that means deep overjet, deep overbite, deep curve speed, you can use S8-SGTB. If you see the condyle resorption will cause the mandible move forward, you can use S8-SGTB to fix it. If you treat some severe skeletal problem, the patient refuses surgery, you can use S8-SGTB. So the next topic is how S8-SGTB works, or the advantage of S8-SGTB. So in one sentence, I will describe how S8-SGTB works. Is S8-SGTB moves teeth efficiently when reposition the mandible. We can have some alignment in the frontal teeth, both upper and lower expansion. We can have some interdigitation in the buccal segment. We can have some molar distalization, which is the best way of the clear aligner. So we will see the first, we can align and expansion during mandibular advancement. We can see the gentleman, young gentleman, is 11 years old boy, protruded lips and snoring. You can see the upper dentition is narrow and crowded, and also crowding in the lower dentition, and deep overjet, deep overbite. You can see retruded mandible. So this is definitely the indication of the S8-SGTB. So for this kind of patient, we can expand the upper dentition and align the teeth with the space we created by the expansion. And also at the same time, we can expand the lower dentition and align the lower frontal teeth. You can see the outcome. You can see this is after the 10 months after the patient's phase 1 treatment, after we remove the mandible, after we move the mandible forward. You can see we have successfully aligned the both upper and lower dentition, and the dental the arch form has been corrected from the sharp to a like rounded shape. And also we coordinate the dental arch, but still we have some space, gaps in the buccal teeth. So just 10 months, we can align the teeth, we can have some both upper and lower expansion. So it's more efficiently. You can see the facial profile has been changed a lot. So only in 16 months, the whole treatment finished. It's more efficient than the traditional SGTB. The whole treatment, you can see. The patient changed a lot. The smile, the facial profile, the mandible has been protruded, and also the airway has been opened. And the next one is about the occlusal settle down. So this is also very important and also the key advantage of S8-SGTB. Why it's so important? If we use the fix of traditional SGTB, when we when we remove the appliance, we will have a huge gap in the buccal segment. It's open bite in the buccal segment. So what can we do? We bond all the teeth with braces, and then we put some elastics in the buccal segment. So imagine if we put elastic in the buccal segment, it will elongate the buccal teeth, the posterior teeth. That will help to increase the lower facial third, and that will help to clockwise rotate the mandible. But the patient, if the patient is still a long facial third, it's like a vertical growth pattern patient, it's not favorable, right? So we want to control the vertical dimension, but we don't have any choice. But if we use S8-SGTB, we can close the buccal open bite by extrude the posterior teeth, or we can intrude anterior teeth, both upper and lower frontal teeth. So we can see this kind of animation. So if the patient is the average to high mandibular angle patient, it's like vertical growth pattern patient, we don't want to increase the lower facial third. We don't want to clockwise rotate the mandible. We don't want to increase the lower facial third. We don't want to extrude the posterior teeth. What can we do? We can have some intrusion of the frontal teeth, maybe the upper and lower. So if the patients just suffer from the gummy smile, we can intrude the upper frontal teeth more. And then after finish, the open bite of the posterior teeth closed automatically. For this kind of patient, you can see 35 years old female, class 2 molar relationship, deep overjet, deep overbite, recline upper incisor, and narrow upper dentition and crowding. So for this patient, we want to move the patient mandible forward. But when we show the picture of the mandibular advancement simulation to the patient don't want this long face. He want to keep her low facial third height. So what can we do? We don't want to extrude the posterior teeth. to close this open bite in the buccal segment. We can only intrude the lower frontal teeth because the patient's the incisor exposure, upper incisor exposure is perfect. So we don't want to intrude the upper frontal teeth. So this is what we do. We have some distalization, some expansion, some IPR in the frontal, and align the upper dentition, align the teeth. And at the same time, the most important is we maintain the thickness of the block of the posterior area. And at the same time, we intrude the lower frontal teeth to leveling the lower curve speed. We just intrude the lower frontal teeth. So let's see the progress of the patient. You can see the 3 months treatment in the phase 1. We align the frontal teeth and we intrude the lower frontal teeth. And the 5th month, you can see when the patient wears this appliance, still the open bite in the buccal segment, the thickness of block didn't change. And the 6 months, you can see after the patient removed the appliance, you can see the gap. You can see the open bite of the buccal segment has been closed gradually. And 8 months, you can see when the patient wearing this appliance, still is very open bite in the buccal segment. But if the patient remove the appliance, you can see almost no gap, just 1 millimeter gap, 1 millimeter open bite in the buccal segment. And the 12 months. So you can see after phase 1 treatment, the buccal teeth bite together, right? It's more efficient than the traditional SGTB. And you can see gradually 3 months, 4, 5 months, 8 months, and 12 months. Because we intrude lower frontal teeth, it will close open bite in the buccal segment gradually and automatically. So we only spend 14 months for this patient. We finish all the treatment. You can see more efficiently. So if it's a high average to low angle patient, we want to extrude the mandible. We want to increase the lower facial third. What can we do? We can gradually reduce the thickness of the block. It will help the eruption of the posterior teeth. And if it's not enough, maybe sometimes we use some attachment help to elongate or extrude the posterior teeth. Or you can put you can bond some lingual button, have some boss elastics to help to erupt the posterior teeth. I will show you my first clear SGTB case. It's in 10 years ago, before 10 years ago. It's an 11-year-old boy and his mother complained about the retruding mandible and the small chin and low facial third. You can see the malocclusion. You can see class 2 molar, deep overjet, deep overbite, and crowding. So for this patient, you can see the very retruded mandible and very small chin. So we want to increase the lower facial third and move the mandible forward. So what can we do? We can gradually reduce the thickness of the block. It will help the eruption of the posterior teeth. And at the same time, we align the teeth. We have some expansion. We align the lower teeth, and gradually make the interdigitation of the posterior teeth. You can see the first month, you can see still it's very thick. And the 3rd month, you can see the thickness of the block has been reduced. You can see gradually the open bite is closed. In the 4th month and the 7th month, you can see the 10th month, after almost we finish stage 1 treatment, you can see almost no block in the posterior area. So if we remove the appliance, you can see almost touch in the posterior teeth. And gradually we reduce the thickness of the appliance so we can close the open bite in the buccal segment for this kind of low angle patient. Only in 30 months, the treatment, the 13 months we finish this case, you can see the treatment, the facial change. So the most important of the most brilliant advantage of the S8-SGTB is molar digitalization. So it's also the great advantage of the clear aligner. I will show you one case, a 31 years old female. You can see the face. It's like a very plain facial area, you can see, and the small chin and the reduced lower facial third. But if we see the facial, if you will see the intraoral photo, you can see class 2 molar relationship, deep overjet, deep overbite, and crowding. So imagine for this kind of patient, what can we do? Is a deep overjet, deep overbite, full unit class 2 molar, crowding. For this kind of patient, do you want to extract any teeth? No, of course no, because the patient's lip is very thick. It's very thick, you can see. And if you want to digitalization of the molar, that's impossible because the 6 million digitalization. Okay, we continue. It's okay. So what can we do with this kind of patient? It's quite complicated if you want to treat this kind of patient without surgery, without extraction, and without digitalization. So what can we do? You can see if we want to crack the overjet, deep overbite, and crowding, we can move the mandible forward. After we move the mandible forward, we can solve the deep overjet, deep overbite at the same time. And class 2 molar to class 1 molar. And at that time, we can have some expansion. We can digitalize the molar both up and lower. You can see we digitalize the molar both up and lower. And one thing I want to mention when we use this appliance to digitalize the molar is if we treat the patient with a traditional clear aligner, we want to digitalize the molar. When the patient remove the appliance, and when the patient biting and chewing, the force will cause the relapse of the digitalization. But when we wear this S8-SGTB, it's a huge open bite in the buccal segment. The teeth won't touch together, so it won't create the relapsing force for the digitalization of the molar. So you can see when we do some digitalization of the molar, when the patient wear S8-SGTB, the digitalization procedure is more efficiently. And I will show you the procedure of the patient. You can see both upper and lower second molar has been digitalized a lot. And this is the elimination, and this is what we get. You can see we start to digitalize the first molar. You can see the space here. And the 10 months treatment, you can see we almost close. We also treat class 1 molar. We can crack the deep overjet and overbite, and we get enough space for the whole dentition alignment. 7 months post phase 1, you can see we get space here, just posterior to the second premolar, and also in the lower arch, we align the teeth much better. And for the phase 2, we have some IPR in the lower front teeth to crack the black triangle and align the teeth, make the indigitation perfectly. We can see the procedure, stage 2. You You can see the progress of the patient. So it's almost finished. So this stage, it's like only 1.5 years. We almost finished the case. So from this full unit class 2, deep overjet, deep overbite, crowding, we can solve this kind of patient with S8-SGTB just by distalization of the molar together with the mandibular position advancement. You can see the treatment outcome, symptomatic. So I will show you the last case. We are combined all this advantage together. The 33 years old female, you can see the lower facial third decreased lower facial third, deep overjet, deep overbite, severe crowding in the lower, and moderate crowding in the upper. And you can see the omega-shaped dental arch. And also we can see scissor spines in the right-hand side and also left-hand side here, in the premolar area. So it's a very severe case. What do we get? We get a full unit class 2 molar, deep overjet, deep overbite, curved speed, scissor spine crowding, and the patient refused any surgery. So this is the cephalometric reading. It's a low angle. You can see FMA and the cephalometric and the CBCT. And when we find the lack of a periodontal condition of the second molar and scissor spine here, you can see the lack of periodontal condition is because of the trauma. So our treatment goal will be align and leveling, achieve class 1 molar, retract the upper frontal teeth, and coordinate the dental arch, crack the scissor spine, reduce overjet and overbite, increase lower facial third, and improve the genio-labial fold because the patient is a low angle patient, like a horizontal patient growth pattern. So the genio-labial fold is deep. So we want to crack this situation. So how to achieve class 1 molar? So we can move the mandible forward. Together, we can distalize the upper molar a little bit. So we can achieve class 1 molar by these two methods together. So how can we align the teeth? Align the upper dentition and retract the upper incisors. We can have some IPR in the frontal. We can have some expansion in the upper arch. We can also use the space get from the molar distalization to retract the frontal teeth. But the most complicated for the patient is the lower arch. Why? We count the patient will have 10 millimeter crowding in the lower arch. So if we want to distalization and the expansion together and with IPR, we need to distalize the lower molar like 3 to 4 millimeters. So if we want to distalize the lower molar 3 millimeter, it will be more complicated for us to distalize the upper molar because it's original full unit class 2 molar. And don't forget the patient's periodontal condition because of the trauma caused by scissor spine. So we have to skip this treatment plan. So finally, we decide to extract one incisor in lower. It will help us to align the teeth more efficiently. So the treatment plan will be use S8-SGTB to move the mandible forward, and together we expand the dental arch, we coordinate the lower dental arch, we correct the scissor spine, we align the teeth, we align the lower teeth by the extraction of the one incisor, and we retract the upper incisor after the stage 1. So this is the treatment plan. So what can we get? You can see the first month, you can see an initial alignment. Also, the scissor spine has been cracked gradually. And we have some cross elastics in the buccal segment. You can see 12 months, what can we get? The scissors bite had been cracked. You can see the arch form has been coordinated much better, and also both for upper and lower. And after we deslice the upper and molar, we get space posterior to the second premolar, and we achieve class 1 molar, and we open the deep overjet and overbite, and the scissors bite has been cracked. So this is what we get and what we designed. So it's quite similar. So it's after 12 months treatment, you can see the labial mental fold has been improved a lot. So this is phase 2 treatment. We continue to settle down the occlusion, align the teeth, have some IPR to retract the frontal teeth, and close the space. You can see what we get. 18 months, 22 months, you can see get some space here. You can see the occlusion has been improved a lot. And 24 months, 26 months, we finished the case. It's perfectly. And you can see the smile and the facial profile. You can see lateral cephalometric and also the OPG. You can see the root parallel, and the periodontal condition has been improved a lot, especially for the scissors bites area. So before and after, you can see we elongate, we increase low facial third, so the patient looked younger, right? The labial mental fold is very deep in the previous before treatment, but now it's much better. Before and after, the arch form has been improved a lot. Before and after, so you can see the condyle morphology has been changed a lot. The CBCT, and this is for 2 years for follow-up. It's very stable, and the periodontal condition has been improved a lot. And smile. So in summary, what is the advantage of a Smarty S8-SGTB? We can reposition the mandible. At the same time, we can correct the individual teeth simultaneously, including alignment, expansion, and desalization of the molar, and make the open bite in the back segment better. And we can correct severe jaw discrepancy without surgery or even without teeth extraction. And this kind of treatment is effective in adult patient therapy. You can see, I will show you many cases. Few patient is adolescent patient and young teenager patient. Almost every patient is adult patient and very stable. And we have used this kind of treatment, like more than 30,000 cases successfully treated in China now.